So if we join these two anterior superior iliac spine, and below that level, the part of the anterior abdominal wall is called the inguinal region. And this region, in this region, we get a specialty. That means the superficial fascia. Actually, we can observe the skin which is continuous from the upper abdominal wall. When we incise the skin from the anterior superior iliac spine up to the midline, from midline up to the symphysis pubis, if we give an incision, then we can remove the skin, the triangular flap of skin we can remove. When we remove the skin, we come across with the superficial fascia. In other parts of the body, you have seen the subcutaneous fat and superficial fascia. And you know, below the superficial fascia, you can expect another fascia, that is deep fascia. Like in your upper extremity, you have seen the deep fascia covering the arm muscles and vessels and nerves. Similarly, in forearm we have seen, and also we have seen in our lower extremity, that is fascia lata, fascia cruris. But in the whole abdomen, including the inguinal region, we do not expect any deep fascia. Why? If there is a deep fascia in the abdomen or in the face, then that part will become fixed. We cannot expand. During respiration, there is movement of the anterior abdominal wall. And respiration is what type of respiration? Thoraco-abdominal type of respiration in adult. Okay. So that thoraco-abdominal type of respiration will get restricted. So nature has purposefully provided no deep fascia in our abdomen and in our face, because in face we use our face, which is called the non-verbal communication, that is facial expressions. So there is no deep fascia. That is an advantage. But at the same time, there is another disadvantage, because due to absence of deep fascia, any infection in the face, especially in the danger area of the face, infection can penetrate inside. Okay. So here, when we are removing the triangular skin, we will get the superficial fascia. And in this region, that means below the level of anterior superior iliac spine, this superficial fascia is splitted into two parts. One is superficial and one is deep part. The superficial part is a fatty layer. It is superficial fatty layer of Campar. And we will get another layer, that is a membranous layer. That membranous layer is that membranous layer of Scarpa. Yes, membranous layer of Scarpa. So that is the peculiarity in this region. And in between, we can expect some subcutaneous blood vessels. One is directed towards the anterior superior iliac spine. One is directed towards the umbilicus. And one is directed towards the symphysis pubis. The vessel which is directed towards the anterior superior iliac spine, which is called superficial circumflex vessels, iliac vessels, superficial circumflex iliac vessels. One is directed towards the umbilicus, superficial epigastric towards the umbilicus, and another towards the symphysis pubis, that is the superficial pudendal vessels. Okay. So there are three vessels we can expect. In a cadaver, we can see these two layers, the fatty layer and the Scarpa, membranous layer of Scarpa. If we can inject, and if the body is very fresh, if you inject some distilled water in between, these two layers gets separated. Now, if we remove that superficial fascia, in the same manner from the anterior superior iliac spine up to the midline, from midline to the symphysis pubis, if we make an incision and if we remove, then we will get the three abdominal muscles from superficial to deep. They are analogous with the muscles of respiration. That means we got external intercostal, internal intercostal, intercostal is intimi. Similarly, they are analogous with those muscles like external oblique, internal oblique, and transversus abdominis. It is recapitulating because many of you were absent on that day. Okay. Because if you don't have any theoretical idea, then you cannot understand the cadaver. Is it necessary or not? Necessary? Then this external oblique, which is analogous with external intercostal, it takes origin from the lower 8 ribs and it goes, the fibers are directed downwards, forwards and medially. Like if you put your fingers in the pocket, taking origin from up above. And all these three muscles, they have got peculiarity. What sort of peculiarity? They are muscular on the lateral part. And as they approach towards the medial side, they loses the muscle fibers and they become membranous or tendinous, and that part is called aponeurosis. So this is external oblique aponeurosis. Similarly, we will get the muscle which is originating from downwards, that is internal oblique aponeurosis, and transversus abdominis, which is taking origin from both from above and below, and transversely arranged. Fibers are transversely arranged. So that also becomes aponeurotic. So external oblique aponeurosis, internal oblique aponeurosis, and transversus abdominis aponeurosis. And in the midline there is one straight muscle on either side, that is the rectus abdominis. And medially, so nature has purposefully made, nature is very much miser. Nature will not give you extra muscle. Rather, here this rectus muscles needs a covering. And that covering is created by these three muscles. That means external oblique aponeurosis, internal oblique aponeurosis, and transversus abdominis aponeurosis. So we will get the sheath on the anterior side and posterior side of the rectus abdominis. So on this side muscle is needed. So all these muscles are muscular on lateral side and they are becoming aponeurotic because medially there is rectus muscle. Medial part is already muscular, no need of giving any more muscle. And these muscles reflexly, these muscles get contracted, get taut, and it has got self-defense mechanism. Self-defense mechanism. Because it protects all the abdominal viscera, whether it is stomach, what is this part of the liver when it is enlarged, when it's spleen, when kidney, small intestine, large intestine, there are so many structures, kidney, okay. So this and pelvic viscera also in the lower abdomen. Now this inguinal region, we will getting all this external oblique, internal oblique, transversus abdominis, and if you go deep to the transversus abdominis, what we will get? We will get another layer, that is a fascia, which is called fascia transversalis, which is intimately attached on the posterior aspect of the transversus abdominis, which is continuous. This is fascia transversalis. If you go more deep to that fascia transversalis, you will enter into the extraperitoneal fatty tissue. You will encounter the extraperitoneal fatty tissue. And if you go more inside, you will enter into the abdominal cavity, but abdominal cavity is covered with a membrane-like structure, very glistening like a bladder, like a pleural cavity. We got one layer is intimately attached with the lung, that is visceral layer, and another layer is reflected, that is parietal layer. Similarly, in the abdomen, one layer is intimately attached with all the viscera, that is visceral layer, and another layer is reflected from this visceral layer and covers the parietes, okay, or the body wall. That is called parietal peritoneum. So, skin, superficial fascia, that means fatty layer of camper, then membranous layer of scarpa, then we will get the external oblique muscle, then we will get into the, we will reach the internal oblique, then we will reach the transversus abdominis, then we will reach the fascia transversalis, and then the extraperitoneal fatty tissue, and ultimately parietal peritoneum. So, if I stab anybody in the abdomen, so I will one by one I will enter in, I have to penetrate all these layers one by one. Then I will enter into the abdominal cavity or pelvic cavity, abdominopelvic cavity. Now, so one specialty is about the superficial fascia, and there is another specialty. In this anterior abdominal wall, in the inguinal region, we will get a canal. This canal starts from a deeper ring and ends in a superficial ring. That is called deep inguinal ring and superficial inguinal ring. And that canal is obliquely placed and covered with muscle and aponeurosis. And that deep ring is situated at fascia transversalis, whereas the superficial ring is situated over the external oblique aponeurosis. Here you can see the pelvis, hip bone, two hip bones and the sacrum creates a basin that is called pelvis. And here we can see this is the anterior superior iliac spine, and here we can get the pubic tubercle. And in between, we can find from here to pubic tubercle, we are getting a ligament. That is nothing but the part of the external oblique muscle. This external oblique muscle, when it is going downwards from anterior superior iliac spine to the pubic tubercle, it gets folded and that part becomes thickened. The thickened part is called the inguinal ligament, and that part which has got the muscle becomes like this, and there is a depressed area which can accommodate something, and this area, depressed area, actually accommodates that the inguinal canal. And definitely that canal is not empty, that canal contains something. In case of male, it contains spermatic cord, and in female, it is a round ligament of the uterus. Now this external oblique muscle, it is going downwards, forwards and medially, and from the anterior superior iliac spine up to the pubic tubercle, it is creating the ligament, that is the inguinal ligament. And here you can see it gets folded like this. and it creates another ligament. The folded part creates another ligament, that is the lacunar ligament, and which has got triangular in shape, which is at the apex is attached to the pubic tubercle, base is free. Okay, this base is free. So this ligament is called the lacunar ligament. So external oblique muscle actually creates this sort of expansions. One is inguinal ligament, another folded part, that is forming the lacunar ligament, whose apex is attached to the pubic tubercle and base is free, and you can see there are two lips, outer lip and inner lip, and this inner lip of this ligament is continuous along the pecten pubis. That means inner lip is continuous through this pecten pubis and up to the iliopubic eminence. Again, I am repeating this lacunar ligament, which has got outer lip and inner lip. Inner lip is continuous along the pecten pubis, and this is called pectinate ligament of Cooper. Pectinate ligament of Cooper. So, whether it is inguinal ligament, whether it is lacunar ligament, whether it is pectinate ligament of Cooper or pectineal part of the ligament of Cooper, they are nothing but they are the derivatives of the external oblique muscle, aponeurosis. Okay, in the lower part it becomes, and medially it becomes aponeurotic. And another part we can see from here, from the inguinal ligament, one part is going medially to get its attachment at the midline. In the midline there is a white line. Alba means white. The fibrous line, that is linea alba. So that reflected part of that ligament is called reflected part of the inguinal ligament. So these are all the derivatives of external oblique aponeurosis. This is the area, this is the inguinal ligament, and in front and behind we are getting the bone, and this area is called pelvifemoral space. So this inguinal ligament, which is attached from the anterior superior iliac spine going medially, and behind we are getting the pelvis like this. Like this. This is the inguinal ligament. So in between the inguinal ligament and the hip bone, we can get an area. That area is called pelvifemoral space, because this inguinal ligament, actually it forms a border between the abdomen and the lower limb. If we cross that ligament, then we will reach the lower limb. The same artery, that is external iliac artery, when it crosses the level of inguinal ligament, it becomes femoral artery. You can see from From lateral to medial, we can see one muscle laterally, that is iliacus, one is psoas major, and medially we are getting the vessels. That is, we already in between iliacus and psoas major, this is the femoral nerve and this is the femoral artery, femoral vein, and this is an open space for the lymph nodes. Okay, so this area is called the pelvifemoral space. Here you can see iliacus muscle, external oblique, internal oblique, transversus abdominis, and you can see formation of the inguinal ligament. Like this. External oblique muscle gets folded and it accommodates what structure? Either spermatic cord or round ligament of the uterus. Now, we are concerned with the superficial and deep ring. Here you can see deep ring, situation of the deep ring, and you can see the situation of the superficial ring, and this is the pubic crest. And you can see this deep ring to superficial ring, we can expect one canal in the anterior abdominal wall. That canal is called inguinal canal. So inguinal canal is a canal where it is present. It is present in the inguinal region or in the lower abdomen, in the anterior abdominal wall, and you can see that canal is parallel, runs parallel to the medial part of the inguinal ligament. Look there, that canal is running parallelly with the inguinal ligament. The whole inguinal ligament has got, we can assume this is the lateral part, this is the medial part of the ligament. So this canal is present in the anterior abdominal wall and it is parallel to the medial part of the inguinal ligament. Now where we can expect this deep ring, deep inguinal ring? This deep inguinal ring is ½ inch above the mid-inguinal point. We are getting the inguinal ligament. This is the midpoint. From the midpoint, if you go ½ inch above, then we can reach the deep inguinal ring. And where is the situation of the superficial inguinal ring? We can see this is the pubic crest. Just above, we are getting a triangular opening within the external oblique aponeurosis, and that is the superficial ring. So, deep ring is circular, whereas the superficial ring is triangular, and which is just above the pubic crest. And this pubic tubercle is a very important clinical point for the clinicians, for the surgeons. This pubic tubercle is very important because above and medial you will get the superficial ring, and through the superficial ring there is protrusion or projection of the abdominal viscera. abdominal viscera may come out through some weak points in the abdominal wall. And those weak points are, this is the deep ring, this is the superficial ring, or through the anterior abdominal wall. So, any viscera may come through this ring, it can travel this inguinal canal, it can come out through the superficial ring, or it can come out directly from the anterior abdominal wall and it can enter into the superficial ring. So that protrusion is called hernia. It is very common. I think it is familiar to you. In your family you can hear hydrocele and hernia, these two entities. Those are the basically the bread and butters for the surgeons, hydrocele and hernia. Okay. So, why this pubic tubercle is very important? Above and medially, if we get the swelling, if any viscera comes out to that area, there will be projection. There will be swelling in the abdomen. So that swelling or hernia is, if it is above and medial to this pubic tubercle, it is inguinal hernia. And if it is below and lateral to this pubic tubercle, this area is called femoral triangle. We know femoral triangle. So this is, we are getting femoral canal. So this is the femoral hernia. So below and lateral to the pubic tubercle, that is the femoral hernia. Above and medial, we will get, if we get the swelling or the hernia, it is inguinal hernia. This is a very good diagram by which you can understand the different layers of the abdomen and the inguinal canal. It is a horizontal section of the abdomen at the inguinal region. Okay? Connecting both the superficial and deep ring. Now, from outside, you are getting the external oblique muscle, internal oblique muscle, transversus abdominis muscle. This muscle becomes, this is lateral side and this is medial side. When you are approaching medially, this muscle becomes apneurotic. So the green one is the aponeurosis. So this is external oblique and this is external oblique aponeurosis. Similarly, this is internal oblique and this is the internal, and it becomes, actually this is separate one, continued. Okay, you can see the internal oblique, you can see the transversus abdominis. These two, transversus abdominis and internal oblique, suppose this is internal oblique and this is the transversus abdominis. When it is approaching medially, these two muscle becomes aponeurotic and this aponeurosis gets fused medially. Or from the right side, this is the internal oblique and this is the transversus abdominis. So these two muscle gets fused. Actually the aponeurosis gets fused and forms a single tendon, which is called as, which is continued as conjoint tendon. So medially we can see Laterally we can see internal oblique, transversus abdominis. These two gets fused and forms this conjoint tendon. So deep to this transversus abdominis, we will get the fascia transversalis. So within the fascia transversalis, we can see one opening, and within the external oblique aponeurosis, we are getting another opening, triangular opening, and this is a circular opening. So this is the pathway which connects the deep ring and the superficial ring. This is nothing but the inguinal canal. So inguinal canal is present in the lower anterior abdominal wall, which extends from, and this canal extends from the deep inguinal ring, which is nothing but an opening, circular opening. It is not, again, if you learn more and more, you will learn this is not an opening. This is the mouth of some other structure. But at this stage, you just learn this is an opening. So that opening is within the fascia transversalis. So that canal, what is inguinal canal? It is a musculo-aponeurotic canal which is found in the lower abdominal wall or inguinal region, which extends from deep inguinal ring to the superficial inguinal ring, and it courses obliquely, parallelly with the medial part of the inguinal ligament. Now why we are so much interested of knowing this inguinal canal? Actually, gonads, whether it is testis or in case of female, that is the ovary. So this is the anterior abdominal wall, and suppose this is the posterior abdominal wall. The black one, just assume that is the posterior abdominal wall. The gonads during embryonic stage develops in the lower thoracic or the upper lumbar region. This is a lumbar vertebra. So lower thoracic, they were placed here or in the lumbar region, either in the from thoracic region to the lumbar region. The developing gonads reside. You will learn it develops from the mesoderm. What is ectoderm, mesoderm, endoderm? Ectoderm, mesoderm, and most inside is the endoderm. So it is developing from the mesoderm and it is placed in the lower thoracic and upper abdominal region. And there is a rope-like structure, but it is not a rope-like structure, it is very much debatable aspect, which drags these gonads from the posterior abdominal wall to the anterior abdominal wall, then up within the deep ring, then superficial ring is here, then it reaches inside the labioscrotal swelling, because at this stage there was no differentiation of the sexes. whether it is male, whether it is female. So that structure which drags the gonad is a rope-like structure. তোমরা তো বিভিন্ন ঠাকুরের ভাসানে দেখেছো, সেটা দড়ি লাগানো হয়, দড়ি ধরে টেনে 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 নিয়ে আসা হয়। বা কোনো মূর্তি দেখেছো, ভাঙতে হবে, ছেনি হাতুড়ি দিয়ে ভাঙতে পারছে না, দেখছি আমরা কি দড়ি ধরে টেনে টেনে তাকে নামানোর চেষ্টা হচ্ছে, তাই না? করে তো, একটা দড়ি লাগিয়ে দেয়, মাথা এখানে লাগিয়ে লাগিয়ে করতে করতে জোর করে তাকে টেনে টেনে নামাবেই। তেমনি in our body there is a rope-like structure which drags these gonads, and that rope-like structure is called gubernaculum. So that gubernaculum actually drags the testis or the ovary from the posterior abdominal wall, okay, then it up to the lower abdomen, and in case of female, there is also a dragging force, but in case of female, the gubernaculum, one end is attached here, another end is attached in the labioscrotal swelling. Labioscrotal swelling, there was a swelling which is called labioscrotal swelling. So in case of male, one end is attached to the scrotal sac, the bottom of the scrotal sac, and another end is attached to the testis, and in case of female, the ovary, and another is attached to the labia majora, that will labioscrotal swelling, which ultimately form the labia majora in case of female. So in case of male, it will drag. So it will ultimately, what will happen? It will come from the posterior abdominal wall, it will go down. Suppose this is the journey, it will come, this is the locus of the journey. So it will come and it will reach the deep ring. When? At 7 months of intrauterine life. It will reach into the deep ring. Then again there will be journey of the testis, it will go down and it will reside at the superficial ring. When? At 9 months. And just before birth, it will come out of the superficial ring and it will enter into the scrotum or the scrotal sac. And that vestigial part of the gubernaculum will form the scrotal ligament. The journey gets restricted due to the growth, due to the development of the uterus, which intercepts the gubernaculum, and the part from the ovary to the uterus becomes the ovarian ligament, and from the uterus to the labia majora, that remains as round ligament of the uterus. So in the inguinal canal, what we will get? We will get a cord-like structure. That is, in case of male, it is called spermatic cord, which extends from upper pole of the testis up to the deep ring. And what are the constituents of the spermatic cord? First is when it is dragging testis along with the vas deferens. So we will get the vas deferens, we will get the testicular artery, we will get the testicular veins, we will get the nerves. Okay, that is the sympathetic and parasympathetic nerves which are supplying the testis, which are coming from the T10 segment of the spinal cord. So any pain over the testis, it is referred to the anterior abdominal wall. Similarly, the same segment is supplied by actually supplies the appendix. So any appendicular pain, it is referred to the umbilicus. So this is spermatic cord and round ligament of the uterus. So the next one is the hernia. Just ছবি দেখে ছেড়ে দিচ্ছি. Now you can see this is the fascia transversalis. That means we have removed external oblique, internal oblique, transversus abdominis. Then we can see this is the fascia transversalis. Here we are getting the ring, deep inguinal ring. And medial to it, we are getting one artery, which is called inferior epigastric artery. Below, we are getting the medial part of the inguinal ligament, and most medially, we are getting the lateral border of the rectus abdominis. So, this forms a triangle. This triangle is called Hasselbalch's triangle. When any hernia projects through this part of the anterior abdominal wall, this is called direct inguinal hernia. And when a part of the viscera, when it enters through the deep ring and traverses the superficial ring, that is the indirect inguinal hernia. Now I told you what are the constituents of the spermatic cord. Vast difference, and you are getting testicular artery, testicular, in case of male, testicular veins, nerves, lymphatics, etc., etc. You are also you will get another content, the nerve which is present in between the internal oblique and transversus abdominis, which is called iliohypogastric and ilioinguinal nerve. That ilioinguinal nerve pierces the internal oblique and then it is continued along with this spermatic cord. So this is the only content of the spermatic cord that is not passing through the deep ring, rather it is joining with the cord, okay, after traversing the medial part of the spermatic cord. Okay. So you can see this is the inferior epigastric artery. So inferior epigastric artery is just below this fascia transversalis, which is a guide to find out this deep inguinal ring. Deep inguinal ring is lateral to this inferior epigastric artery. Okay. Now we will try to find all these structures here.